intensive care. So today I'm going to give you a brief introduction to the critical care issues related to the COVID-19 patients and some advices that I can give you how to manage the issues, these issues. So to give you an overview of our ICU, this is a typical room in the ICU in our department, with the patient being in the central position and surrounded by monitors and IV pumps and computers. So I don't know if this is similar to the ICU settings which you are used to, but I will talk my point of view regarding this setting. So if you have questions or remarks, you can ask them at the end of the presentation. The COVID-19 disease started in late 2019 and originated from Wuhan, China. And it developed into a pandemic real soon, in a matter of weeks to months. At this moment, we don't have a cure for this disease. And this disease, when developed to a severe illness, it manifests itself as a pneumonitis and ARDS, with the mortality and morbidity coming specifically from these two characteristics of the disease. Let's focus on how many people of the infected are required to be admitted in the ICU. We can see that it's depending on the region on the world. 5 to 2% of the infected require ICU admission. In China, this seems to be a bit more than in the United States and in Europe, where it's between 5 to 12% of the infected. So the contaminated population, almost 1/3 of the population has no symptoms at all, but they are contagious up to 2 weeks. And the majority will experience mild or moderate symptoms, and the patient with severe symptoms who require hospitalization or ICU admission, those are around 10 to 15%, and those patients are contagious, the whole period that they are in the hospital or in the ICU. So some clinical features of the disease. I will not go over all of the features. I will only go through the critical ill COVID-19 patients. So when there's a patient who has a rapid rate of progression of the disease, which will include critical illness, and that includes ARDS, they typically develop dyspnea around 6.5 days after the onset of symptoms, which is relatively late compared to other ARDS diseases. But the progression from dyspnea to ARDS is rapid, 2.5 days after dyspnea. So some risk factors to develop the critical illness is predominantly age and comorbidities, and age above 65 and 70 is a predictor of critical illness due to COVID-19. Another predictor is a history of smoking or pulmonary diseases in the history, such as asthma and COPD. And if the patient presents itself with a high fever above 39 Celsius, he also has a high risk of ending up in the ICU and mechanical ventilator. So the disease itself can be described as acute hypoxemic respiratory failure. And we can see rarely that the patients are hypercapnic. This is due to the high lung compliance at the start of the disease. Of the critically ill COVID-19 patients, we can see that 42 to 100% of the patients require ICU admission for mechanical ventilation. This is dependent on the availability of the resources and the region of the world where the patient is originated from. Some common complications when the patient has COVID-19 disease is acute kidney injury, and many patients also require renal replacement therapy. Another major complication can be the cardiac injury. You can think about cardiomyopathies, arrhythmias, ventricular fibrillations, ventricular tachycardia, pericardial effusions. These symptoms can also be the presenting symptoms of the patients who present themselves in the emergency department with ventricular fibrillation as a result of COVID-19. What we also see is elevated liver enzymes of the critically ill. Less common complications are sepsis and shock. For the patients who are not intubated, the need for vasoactive agents is really low. We will come back to this later when this will change. And we also don't see a lot of multi-organ failure due to the COVID-19 disease. We do see a lot of pulmonary complications. The exact numbers are yet unknown, and because it's a relatively new disease, but the Chinese report up to 12% secondary pulmonary infections. This may be due to the high rate of glucocorticoid steroid use in China. What we see is, as I mentioned before, that these patients have a high lung compliance, with a low rate of barotrauma and a low rate of pneumothorax. A lot of these patients, around 50%, present with delirium or encephalopathies, and they have symptoms like agitation and confusion. Later, in a later stadium of the disease, they have a high sedation requirement, especially right after the intubation. So when the patient is severely ill, initially we see modest laboratory abnormalities like leukopenia, lymphopenia, leukocytosis, lactate, and elevated procalcitonin. We do see elevated digimers. This can be due to the pulmonary embolism, and this is really common in COVID-19 patients, more common than other ARDS type diseases. So some patients develop vigorous inflammatory response, which can mimic cytokine release syndrome with persistent fevers, elevated inflammatory markers, and this has poor prognosis for the patient. You can also obtain some imaging, so obtain a chest radiograph if available, and do a point-of-care ultrasound. This can also provide information which can be useful in a later stage when the patient is in need of mechanical ventilation. You should do only a CT scan if it will change your management and if it's available, of course. And if you do a CT scan, you can divide the patient according to the CORADS score, which you can see here below. So this is a really nice overview of the disease, which is a multi-stage disease and fluent. So it starts with low severity, and in the early stage of the disease, the stage 1, is mostly a viral response phase with mild symptoms. The patients usually don't need to be hospitalized. In stage 2, you can see that the viral response phase goes into the host inflammatory response phase. And this can develop in some patients in hyperinflammation response. And these patients will develop ARDS, SIRS, or shock, or develop cardiac failure. And in the lower section of the graph, you can see the potential therapies. As I mentioned before, at this moment, there is no cure or developed. These are all experimental therapies at this moment. So the care for non-intubated patients who are still in the ward should be to try to oxygenate the patient to achieve a peripheral saturation between 90 to 96%. You should titrate to achieve the lowest fraction of inspired oxygen. That's also called the FeO2. Yeah, some patients do require higher or lower targets. For instance, patients who have a history of COPD or pregnant patients, and those patients require higher peripheral saturations. So you should individualize your therapy at all times. So if the patient does need oxygen therapy, you should start with a nasal cannula, which can provide up to 6 liters of oxygen and has a low degree of aerosolization. It is important that that the patient wears a droplet mask to reduce the risk of contamination of the surrounding environment. This is also the preferred way of administering oxygen to the patient. If this proves to be insufficient, you can try the face mask, venturi mask, or the non-rebreather mask, which can provide 10 to 20 liters of oxygen per minute. This does not have the performance because of the high risk of droplet dispersion, and the staff and the nurses should take appropriate personal protection. Another good thing to keep in mind is to advise the patient to use wake proning, in which the patient will lie on in supine position for a few hours and change this in proning position for a few hours and change it back as long as it is possible. If the low flow oxygen therapy proves to be insufficient, so you can also use high flow oxygen. The first modality of that is the high flow nasal cannula, also known as Optiflow. It is preferred in younger patients without any comorbidities because it can postpone the need for intubation. In some cases, it can avert an intubation, but it is important to monitor the patient and do regular arterial blood gas evaluations and proceed to direct intubation in absence of effect. Another modality is the non-invasive ventilation. And this is not recommended because in the literature there's a high rate of failure. And it also has a high rate of droplet dispersion and contamination of the surroundings of the patient. But it can be useful in patients who are in hypercapnic respiratory failure or who have pre-existing conditions like obstructive sleep apnea syndrome. Both of these modalities have, again, high rate of aerosolization. So you should protect yourself and protect the other staff when caring for these patients, which consists of an N95 mask and protective goggles. So when you do decide to intubate the patient, the timing is really difficult in my experience, because we know that most of the ARDS patients require intubation and mechanical ventilation. Delaying this can be harmful for the patient and also for the staff because of the higher risk of contamination. So we advocate to early intubate the patient if necessary. but it can be tricky because the patients who have COVID-19 and are hypoxemics have a high lung compliance, at which point they are not hypercapnic and they can feel the being fine, but their blood gas and peripheral saturation can deteriorate really fast without them feeling dyspnea. So you should have a rapid threshold to intubate the patient if the patient's disease is rapidly progressing over hours. And if you have tried to give the patient high flow nasal cannula without any success, and the FiO2 is about 60% with a 40 liters per minute. Another group of patients are patients who are becoming increasingly hypercapnic, have an increased work of breathing, tidal volumes, or have delirium due to hypoxemia. And of course, patients who are hemodynamically unstable or have multi-organ failure should be intubated. The intubation itself is a high-risk procedure, and it should be done by the most qualified individual present at the moment. Mostly it is the anesthesiologist or an experienced ICU doctor. And I recommend you use intubation kits and checklists. And so at the beginning of every shift, there should be a designated physician or a nurse who checks the contents of the intubation kit and goes through all the checklists if everything is available. That includes full contact and personal protective equipment for the team that is intubating the patients. This includes an N95 mask, protective goggles, face shields, gowns, caps and beard covers, protective footwear, and gloves. Preferably intubate the patients in an ICU setting or in the OR if possible, but if not, then try to have a few as possible people in the room when intubating the patient. Pre-oxygenation is really important when trying to intubate the patients, but you can do this with the aerosolization. So you should use the non-rebreather mask with 100% oxygen. And after the patient is induced, sedated, you should avoid bag mask ventilation. If you do need to use bag mask ventilation, use a filter and use a second person to assist you, and use clamps for reconnecting to the mechanical ventilator. So the ventilation management, this is also a multi-stage management. So we have the early phase and the latter phase of the disease. The early phase is characterized by severe hypoxemia, high compliance, and low alveolar recruitability. This is an atypical ARDS. And the latter phase is characterized by severe hypoxemia, low compliance, and high recruitability. For the first phase, the early phase, we also call it the phenotype L. It can progress to the latter type in the same patient. So it's not so that if the patient has the phenotype L, he cannot have phenotype H. It can progress to the phenotype H. You should always keep that in mind. For the first group, you should use the lower PEEP, higher FiO2 table, and for the latter type, you should use a higher PEEP, lower FiO2 table to provide adequate oxygenation for the patient. You should do regular arterial blood gas controls if the patient is ventilated to see whether or not you're adequately providing oxygen. the initial settings of your ventilator should be less than 6 kilos of predicted body weight for the tidal volume.
دکتر سوغری یک لحظه ببخشید. امی سلاید که هستین امیر لطفا نامش بگیرین بعضی که من نمیفهمم کارهای ما در افغانستان امی سلایدا شما تعقیب میتونن و یعنی که امی سلاید که هستن نام میبینن دقیقاً باز اینا فوق کردن نمیتونن معذرت میخوام.
Low tidal volume is the title of the page.
Just the number of it is also okay, I think. Okay, go further. Go on.
Is it okay now?
Yeah, which slide is it? The number of the slide. Just call it when you present. Say which slide is it? 20.
So the initial settings of the ventilator should be less than 6 milliliters per kilogram of predicted body weight for the tidal volume, and avoid plateau pressures above 30 centimeters of water. And titrate your PEEP according to the PEEP FiO2 table provided earlier. And the ventilation rate should be less than 35 per minute, but you should match this again for the minute ventilation of the patient. So the goals when ventilating the patient through the mechanical ventilator is similar to the non-intubated patients. So your goal should be to achieve a peripheral saturation between 90 and 96% with a pH above 7.2. If this fails and you cannot achieve this, there are a few ways to a few treatments for the patients. The first one is the use of neuromuscular blocking agents. If you use these agents, you should also use a train of four watch to see whether or not your treatment is working. Another one is to ventilate the patient in prone position, which will improve the ventilation perfusion mismatch and also will recruit the lungs of the patient. You can use this if the patient has a PEEP above 15 centimeters of water and FiO2 above 60%. You can also try to recruit the patient whether or not in supine or prone position and try a higher PEEP. Another treatment would be the use of pulmonary vasodilators, which will improve the ventilation perfusion mismatch. The most common used agents for this are nitric oxide and inhaled prostacyclin, but you need to have appropriate equipment to make use of these agents. So for the sedation of the patient, we advise the use of short-acting sedatives, such as propofol and remifentanil. If you think the patient is going to be needed to be sedated for more than a few days, you can use midazolam and sufentanil. We know that these patients require high sedation, so co-administering ketamine and clonidine can be useful in these patients. If the patient is weaned from the mechanical ventilator before the extubation, you should do a spontaneous breathing trial to see whether or not the patient is able to be extubated. Please note that there is a high rate of re-intubations, and so when you extubate a patient, have a skilled staff present in the ICU who can re-intubate the patient if necessary, and also perform the extubation in an isolation room if possible, with all present staff wearing personal protective equipment. So what can you give to the patient? This is all experimental at this moment. Chloroquine or hydroxychloroquine is one of the agents we give to the patients. And with these agents, it's important to monitor the EKG specifically the QT time of the patients, which can be prolonged due to these drugs, and can cause arrhythmias. If you have experimental medication available and the patient is considered a potential candidate for this, I do recommend using it, but I don't know if there are trials going on in your hospital. Furthermore, it's important to keep the fluid balance as negative as possible while monitoring the renal function. You should not, not at all costs, of course, creating a negative fluid balance. So supportive care. We know that the COVID-19 patients have a high rate of thromboembolisms, especially in the lungs, pulmonary thromboembolism. You should use a low molecular weight heparin as a prevention of this. And if the patients have pulmonary embolisms, you should use heparin or any other adequate drugs to combat this. And furthermore, you should keep in mind that the patient needs the usual IC care, which all patients need, like nutritional support, stress ulcer prophylaxis, and the prevention and treatment of ventilator-associated pneumonia, because the COVID-19 patients usually are 2 weeks or more dependent on the ventilator. We can see also secondary infections such as the Aspergillus in these patients. We do not recommend the use of glucocorticoids as standard therapy, only if needed and indicated, because it can create other difficulties in these patients, such as infections. So to summarize what I've told you earlier, this is the overview of the disease in different stages. The first stage and the early stage is mainly the viral response phase, and the latter phase, in which the patients are critically ill, is the host inflammatory response phase, in which the patients develop ARDS and need mechanical ventilation. So the oxygen support for non-ventilated and intubated patients is a peripheral saturation goal between 90 to 96. You can use a nasal cannula, which is the preferred form, to give up to 6 liters of oxygen per minute. And you can use a non-rebreather mask to give up to 10 to 20 liters per minute of oxygen. The use of high flow nasal cannula and the non-invasive ventilation is controversial. Non-invasive ventilation is not recommended. You can try to use high frequency, high flow nasal cannula to avert or postpone intubation in some patients. But you should be vigilant that these patients still should be monitored every 1 to 2 hours. Or sooner if their peripheral saturation is less than 90%. Again, the intubation indications, if the patient shows any sign of respiratory distress, you should have a low threshold for intubation, rapid progression of the disease, low saturation despite maximal supplemental oxygen is an indication for intubation. And arterial pH below 7.3 is also considered an indication. And the other two we already discussed earlier. So patients who are hemodynamically unstable and have multi-organ failure should be intubated. So the ventilator settings should be to provide low tidal volumes with targets around 6 milliliters per kilogram of predicted body weight. Your ventilatory rate should be around 25 to 30 to start with, and your goal to go as low as 10 to 15 breaths per minute. And you can use to start a PEEP around 10 and titrate the PEEP according to the PEEP FU2 table provided earlier. And again, the target for your oxygen should be between 90 to 96%. Avoid plateau pressures above 30 centimeters of water. And for the intubated patients, the goal for the pH is above 7.2. This was a brief summary of the care for the critically ill COVID patients. I hope it was clarifying a bit. And if you have any questions, I'm happy to answer them.
Thank you, sir. Sir, you said in the fluid balance that keep it in negative side. What do you mean by negative side?
Can you repeat the question, please?
In fluid balance issue, you said that keep it in negative side or negativity.
Yes.
What do you mean by negativity?
So when the patient is critically ill, he or she needs a lot of fluid to maintain adequate blood pressure. In a later stage of the disease, you should try to give them medication to get rid of the excess fluid which is in the body present, such as furosemide or spironolactone.
Thank you.
Kayo, matawag mo kayo. Yeah, it's just. Can you tell management? Nami awas mo kayo mera.
میتونید سوال تا بکنین به دری یا میتونین سوال تا بکنین پروا نداره ما سوال با سعی میکنیم که به دری یا به انگلیسی جواب داده شه ولی سوالتان ارتباط به تداوی مریضای کووید داشته باشه و در ICU
تداوی میگی. تداوی چی گفت؟
بفرمایید صدایتان میه سوال دارین
There is a question about the meningitis management, COVID-19.
I do want to add a comment about hydroxychloroquine. I agree with the lady from the US, with Dr. Fauci. I think in the Netherlands also most centers use it to within scientific trials, medical trials. Our centers also in the Amsterdam did use it, but we stopped using it, and now it's only used in with medical trials. And we also had recently a very severe complications of hemolysis due to G6PD deficiency, which is also very common in Afghanistan.
Thank you. دکتر گهیس شما سوال داشتین بفرمایید مایکتان چالان میکنم بفرمایید دکتر گهیس
My question is about the basic mechanism of the hydroxychloroquine in the COVID-19 patients. That and by which mechanism it is beneficial in the patient of the COVID-19. Thank you.
Your question was not clear. Could you repeat again?
The mechanism of working of hydroxychloroquine, he means.
Okay, it's good. If you understand the question, if
Yeah.
you got it, Dr. Noor, you can reply on that.
Yeah. Okay, thank you. So this is a very interesting question. Actually, the data came from treatment of SARS in 2002, 2003. It showed that it does inhibit, it stops viral replication in the lab, but it didn't have any effect in SARS patients. And now with this crisis, this pandemic, there was hope that it would work also in this patients. And what it does, it changes the pH value in the cells in the plasmatic system, and by that way viral replication decreases. And the other effect of hydroxychloroquine specifically is anti-inflammatory. So there is some hope that it will decrease the inflammation ARDS in the lungs. So that would be the explanation. But unfortunately, as often the human body is not the same as the lab, so we will need to see the results of well-designed trials if it does help in human beings.
Is your questions answered, Dr. Gahiz?
Yeah, thank you so much. Thank you.
Okay. Dr. Ataullah Uriakhil has a question. Please ask your question. Dr. Ataullah Uriakhil, your mic is on. بفرمایید. بفرمایید. صدایتان هم میشنویم. دکتر صاحب اوریاخیل.
Okay. My question is about hydroxychloroquine.
Okay.
That healthcare workers can use it prophylactically.
What was your question? We couldn't have it clear.
Prophylactically, I mean.
Okay. Irfan John, if just reply on that if you would like.
Yes, thank you. I wouldn't recommend that. As my colleague Dr. Harith explained, there are a lot of side effects. It is and of course the pandemic will be there for a long time, so you will have to take it for a very long time with all its side effects. So there are some centers in India who have started using it prophylactically, but in the Netherlands we don't. I think most countries don't, and there's very little evidence for its effect in prophylactic settings.
Thank you, sir.
Okay, there was a question about corticosteroids. Who asked it? Please come to the mic and ask your question.
Hello?
Okay. Yes, ask your question, please.
Dr. Fawad from Afghanistan.
Okay. Ask your question, Dr. Saifawat.
Yeah, our colleagues in the COVID-19 hospital asked me to about the use of corticosteroid in ICU patient, in which stage or in which, according to which eligibility criteria to start corticosteroid in those patients.
I will pass this question to Dr. Noor or Dr. Faiz.
It's in ICU setting, so maybe Dr. Gharif can answer.
Oh yeah, Dr. Gharif, you can answer as well.
So from the data we have available from China, we can see that the overuse of glucocorticoids in the early stages of the disease leads to secondary complications such as infections. So we recommend using glucocorticoids in the stage of the disease where the patient has refractory shock. So the patient is has a severe ARDS and has shock due to the inflammatory response, to tamper the inflammatory response. So when the patient has the need for high dose vasoactive medications, in addition to the ARDS, we recommend using the glucose steroids, not in every patient who is admitted to the ICU. But I know this is also a controversial topic in which some countries have a low threshold for using glucocorticoids.
Okay, thank
And
you.
if I may add,
yes, of course.
If I may add,
of course.
outside ICU setting, we also don't recommend using corticosteroids systemically. There are some signs that if you inhalation corticosteroids would be no problem.
Okay, thank you. There was a question from our colleague Dr. Saib Aziza Azarmir. شما سوال داشتین اول به شما نوبت است، بعد از او باز دکتر صاحب اوریاخیل میتونه سوال خود بکنه. دکتر صاحب عزیزه ازرمیر بفرمایید.
بشنوین استاد صدامو؟
بله میشنویم، بفرمایید.
استاد محترم بسیار زیاد تشکر از لکچرتون. هرچند من پسان وصل شدم، امی منیجمنت مریضایی که مصاب سیکدی هستند پیش مریضای کووید 19
صدایتان قطع وصل
ما
میشه
داریم
دکتر
که
صاحب. دکتر صاحب میتونین سوالتان پس دوباره تکرار
مصاب
کنید؟
سیکدی هم هستن و مصاب کووید 19 شدن. فعلا منیجمنتشون چه داره که منیجمنت کووید 19 نزد مریضایی که مصاب سیکدی هستن استاد میخواستم پرسان بکنم که چه قسم بهتر است؟ بله
chronic kidney injury, I think she means.
بله استاد.
Chronic kidney injury.
بله هدفشان
بله
chronic kidney disease است.
بله.
Yeah, the management should be the same as with any patient with severe illness, critical illness, admitted to the ICU. So, yeah, if the patient is in need of renal replacement therapy, although it can be temporarily, they should receive this. So, continuous venous hemofiltration is an option.
سوال شما جواب سوالتان نگرفتین دکتر صاحب عزیز از ارمیه؟
بله
تشکر
بسیار زیاد.
خواهش میکنم. دکتر صاحب عطاالله اوریاخیل، شما میتونید سوالتان سوال کنین. دکتر صاحب اوریاخیل، مایک شما چالان است. دکتر صاحب اوریاخیل. خب کسی دیگه سوال داره یا تمام سوالا؟ دکتر صاحب بصیر رحیمزایی بفرمایید.
سلام
مایک شما
علیکم.
چالانه، بفرمایید.
استاد محترم دور بخیر، صحتمند خوب هستین؟
و علیکم سلام، شکر الحمدلله، بفرمایید.
استاد از این پرسان میکردم که آیا امی پشک هست میتونه همین مرض کووید 19 را انتقال بده از یک انسان به انسان دیگه؟
سوال خیلی خوب است. کسی جواب داره به این سوال؟ یعنی سوال شانی است که آیا امکان داره که پشک یا کسی که مصاب مریضی کووید 19 باشه؟
Thank you. My question is about the.
بفرمایید.
Okay, thank you. My question is about the painkillers. Which kind of painkillers can we use for the COVID-19 patients? Yes.
In the ICU setting, we recommend using paracetamol and opioids as a means of pain medication. You also can use clonidine, which also has analgesic qualities. We do not recommend using NSAIDs such as diclofenac, ibuprofen in the ICU setting.
دکتر صاحب نورم میخواستن که ریپلای کنن. بفرمایید دکتر صاحب.
So about insects, if it's transmitted by insects, I don't think so. It's not a typical blood-borne disease. So the chance of an insect pasha to transmit it from one patient to other patient is very low. There are no have not been reports of transmission by these kind of insects.
Thank you very much. Are there any other questions? بفرمایین. کی سوال اول از کی بود؟ بفرمایین. بفرمایین محمد ادریس، سوالتان بکنین. مایکتان باز است.
سلام مجدد.
بفرمایید. علیکم سلام.
ببخشید استاد محترم، یک بخش سوال من ماند. من گفتم مریضایی که هایپرتنشن از باعث کووید 19 پیدا میکنن که اکثرا در اتوپسیا مریضایی که فوت کرده گفتن از باعث هایپرتنشن و فوت کردن، احتمالاتش چی است اگر مریضایی که قبلا آیشدی داشته باشن و نزد از این مریضا ادویه هایپرتنشن چه رقم تنظیم میشه؟ تشکر.
خواهش میکنم.
Do you mean the patients who develop hypertension in the ICU setting or with chronic hypertension as a pre-existing condition?
میشه که قبلا هایپرتنشن نداشته باشه در اثر کووید 19 پیدا کرده باشه هایپرتنشن، به خاطر که ما یک ژورنال خواندم اکثر کسایی که در اثر کالبد شکافی پیدا کردن سابقه هایپرتنشن نداشته، ولی در اثر هایپرتنشن و بعضی چیزهای دیگه فوت کرده. هایپرتنشن در اثر کووید 19 پیدا کردن.
I'm not aware of this complication. Maybe Dr. Noor can answer this.
So I'm neither, but it could be that it's because it just cause a lot of vascular inflammation. That it maybe in some cases it causes thrombotic microangiopathy. It also causes kidney injury. So from there also with glomerulonephritis you can have sometimes hypertension. But I'm not aware of any direct, very often occurring complication of COVID-19.
Yes.
بله دکتر صاحب فیض بفرمایین شما میخواستین چیزی بگویید.
بله سلام به همه. به نظر من تا حال there is no evidence that COVID-19 is associated in some cases which was pointed by colleague Noor. Patients maybe develop no evidence that all patients with COVID-19 develop hypertension. There's also some discussion whether you can use ACE inhibitors. Studies have showed that there is no evidence so that ACE inhibitors.
We don't hear you. We don't hear you properly, Dr. Faiz Karim. Could you do something about your mic? Your answer is very interesting and also I think helpful for our colleagues in Afghanistan, but we don't hear your voice clearly. Could you repeat your answer again?
حالا درست میشنوین؟
بله حالا میشنویم.
خب I was talking about ACE inhibitors. There's some discussion if ACE inhibitors are contraindicated in COVID-19. There is consensus of some Society of Cardiology. They say that you can use ACE inhibitors safely. To be as answer for the question, no clear evidence that COVID-19 is associated with hypertension.
اوکی. جواب سوال شما درست شد دکتر صاحب؟ به ارتباط فشار خون و کووید 19 یعنی کدام تا به فعلا کدام تحقیقاتی وجود نداره و چیزی که دکتر صاحب نور تشریح کردن خیلی جالب بود. خب
خود دکتر صاحب چی نفکر کردم what does doctor himself think? Maybe he knows he
yes,
has
of
read
course,
something.
yeah. دکتر صاحب محمد ادریس مایک is yours.
دقیقاً تشکر سر زیاد تشکر.
اوکی. تمام سوالا جواب داده شد یا کسی هست سوالی داره؟
من یک سوال دارم استاد.
بفرمایید صاحب بفرمایید.
استاد جان
من هم سوال دارم.
اواخر میشه من اول سوال خود بپرسم؟
بفرمایید بله شما اول سوالتون بپرسید. خودم
خود
کوتاه معرفی کنین بگین از کجای افغانستان کی ما
دکتر بصیر هستم از ولایت دایکندی.
بفرمایید دکتر صاحب بصیر.
دمی اواخر وزیر صحت عامه در یک وایس و همچنان در کلیپ گفته بود که شما دمی رمضان پس از افطاری غرغره کنین، مثلا همین نمک دوا بندازین و بالاخره غرغره کنین، چندین بار غرغره کنین. آیا میتونیم مکانیزم نظیر بگوییم که چی اثر داره همراه بالای ویروس که همین غرغره کردن و همراه همین نمک و همین چیزا که یا همین یک کامباینیشن جور کرده چی اثر بالای همین ویروس داره که ما را از این نجات بده؟ به نظر من آیا تاویش گفته یا از واقعیش گفته؟
تشکر. بفرمایید دکتر صاحب نور یا دکتر صاحب فایز یا دکتر صاحب غریق بفرمایید.
I really want to answer this question, please.
Please.
Because I totally disagree with this. This is it's very dangerous to spread this kind of misinformation because it puts patients in danger of being careless. So there was a research from some 2 years ago in Germany that tested salty solutions in viruses and bacteria, and it had some effect in lab. So I think it would have some effect also in the mouth, but it only for a few minutes. And the trouble is that this virus gets through also enters through the nose or through eyes, and so you would need to wash your eyes and nose and mouth 24 hours a day to prevent it from inhaling. So after 2 minutes, it can inhale, and then it goes down to the throat and onto the lungs. So there is absolutely no evidence for salt solutions to prevent this disease, unfortunately.
I totally agree with Dr. Noor. It is dangerous to spread these kinds of misinformation as people would assume they are safe. And yes, I don't know where this kind of information came from.
دکتر صاحب بسیر قراره که فکر کنم که جواب به سوالتان داده شد که اصلا کدام تحقیقات تا و فعلا نشان داد. بله.
اما یک وزیر ساتامه ما که با مردم عام از خان میته و ما که در یک ساحه ولایتی همونجا دکتر هستیم از ما میپرسانا رو میکنه که اصلا اینی کدام علت داره که همی ویروس از بین ببره، به خاطر از که آیا کدام میتونه رقم شرایط وجود داره که وزیر ساتامه به کلگی یک وایس میکنه که شما اینی کار کنین. به خاطر از این یک پرسان کردم. تشکر. زنده باشید.
خیلی سوالتان بجای است، سوالتان کاملا بجای است. خدا کنه که جوابش هم گرفته باشین. چرا دکترایی که ما امروز همراه ما داریم یعنی مکملا آپ تو دیت سوالایتان میخواین جواب بدن. طبعا ما از شما چیزی میآموزیم، اگر در صورت چیزی باشه معلومات شما داشته باشین میتونیم. فکر کنم که یک سوال دیگه کدام کسی ده. فقط 5 دقیقه دیگه ما وقت داریم، میتونیم که به سوالات جواب بدیم. میفهم که سوالات بسیار زیاد است و در غیر از او اگر که دکتر صاحبای ما میخواستن باشن به سوالات جواب بدن، من هم هستم. اونام اسکیجولشان فکر کنم که خیلی زیق است. اگر دکتر صاحب نور و دکتر صاحب فایز و دکتر صاحب غریق زیادتر میخواین باشن، چرا خیلی سوال است ما که میبینم. بفرمایید دکتر صاحب مسئول هاشمی، شما سوال داشتیم.
سلام به همگی. بازم خسته نباشین. از سوال ما از دکتر صاحب اسماعیل غریق بود که اینا کدام مریضا را با نان اینویسیو ونتیلیشن در آی سی یو اینجا کیور میکنن و کدام مریضا را با اینویسیو ونتیلیشن، و چون آوتکمی که اینا از اون مریضا دارن چی است؟ به خاطر که دکتر صاحب انصاری هم در مسیج این سوال پرسیده بودن و ما هم همین موضوع را خواندم در چند ریسرچ که شده در امریکا. مورتالیتی در نزد کسایی که اینویسیو مکانیکال ونتیلیشن تحت از قرار گرفتن بسیار زیاد بالا بوده نسبت به کسایی که با نان اینویسیو ونتیلیشن قرار گرفتن، و اما آوتکمی که در امریکا بوده از نان اینویسیو ونتیلیشن بهتر و بالاتر بوده. دیگه سوال ما از دکتر صاحب غریق که خود شما عملا از کدام نوازی بیشتر با مریضا را منیجمنت میکنی و آوتکمی که شما دارین چی هستن؟
بفرمایید دکتر صاحب غریق.
So for me, just to understand your question is about whether or not non-invasive ventilation is better or superior to invasive ventilation, mechanical ventilation. Is that correct?
Exactly, yes.
Yes. So there are a few things you should keep in mind when comparing the numbers between the United States and the numbers that we have here in Europe. In the United States, the disease is the pandemic is at an earlier stage in which mostly the elderly people are falling, becoming severely ill. So the patients who are in need of mechanical ventilation in the United States are usually the patients who are older, and the population in the United States is more obese and has more comorbidities at the age that they are admitted in the ICU. In Europe and in China, we saw that the patients who are morbidly obese or are older have a bad survival at the mechanical ventilation. But it's also when the patient is non-invasively ventilated, it has a bad outcome depending on its age, comorbidities, obesity rate, and the pre-existing history of smoking. So to compare these two modalities as one being superior to the other is not really relevant at this moment if you compare the numbers from the United States. Because in the United States, the patients who receive non-invasive ventilations are usually younger, have less comorbidities. We in the Netherlands do the same. So patients who receive high flow nasal cannula are usually younger and have no comorbidities, but it doesn't prevent them from being intubated and mechanically ventilated.
Is your question answered, Dr. Sebashimi?
Yes, yes.
Thank you
yes,
very much.
Of course. Thanks a lot, Dr. Seb.
Dr. Seb Shariwar, بفرمایید.
سوال
دکتر سب شریوار شما سوال
با عرض سلام، دکتر شریوار هستم از بدخشان. سوال ما در مورد ازی بود که در صورتی که ماشین ونتیلاتور موجود نباشه چی کمک کرده میتونیم به مریض؟ تراخستومی استباب داره؟
If there is no ventilator available, tracheostomy is it has no place in trying to provide the patient with more oxygen, because it's not an airway issue, it's an oxygenation issue. So the problem is in the lungs, not in the airways. And secondly, if the patient doesn't respond to conventional therapy, you can try the awake proning, which we discussed in the presentation.
سوال شما جواب داده شد دکتر صاحب شریوار؟
بله بله، تشکر.
دکتر صاحب اجمل زاهد شما هم سوال داشتین، بفرمایید، مایکتان باز است.
بله بسیار زیاد تشکر از شما و دکتر صاحب غریق تشکر میکنم. من هم اجمل زاهد هستم از کابل، شما رو زحمت دادیم. ما کارمند هستم در وزارت صحت عامه، قسم کارم از ولایت دلگوندی. همچنان اشاره کردن استفاده کردن از آب نمک به خاطر از بین بردن ویروس و ایره شما رد کردین و فکر کنم کدام اویدنس پیش خود داشتین. ما خوشحال میشیم که شما اویدنس خود ما شریک بسازین و کدام ریسرچ و آرتیکل اگر در این باره هست که ما هم میره به وزارت صحت عامه به همکاری خود برسانیم که نوچتو به کدام دلیل دیگه بخوای گفتین که ما این دو اویدنس سر بدیم کدام شما حقیقت در کل بیان میکنین. ما بخی کنفیوز شدیم به خاطر که شما اینجا میگین که این کار اشتباه است و درست نیست. ما اویدنس داریم و تحقیقات شده، اما وزیر صحت عامه که به سطح یک وزارت در افغانستان حضور داره و در بخش شبکه تلویزیونی جهانی یا همه مردم دعوت میکنه که شما از آب نمک استفاده بکنین و بسیار خوب است و رفرنس هم میده کشور آلمان کی استفاده کرده و موثر بوده. میشه شما اویدنس خود از طریق ایمیل به ما شریک بسازین که ما به همکاری خود برسانیم که با ورزش و وزیر میتونم برسانم که شما به کدام اویدنس و ایگا گفتین و اگر شما گفتین به کدام اویدنس گفتین. تشکر بسیار زیاد.
تشکر بسیار زیاد. دکتر صاحب نور اویدنس برای ما امرای ما شیر میکنم، من شما را در ایمیل دارم، حتما براتون روان میکنم چیزی که به دست از ما میایه. ولی یک گپ فراموش نکنیم که در جامعه علم استوار به تحقیقات است و بحث همیشه جریان می داشته باشه. طبعا ما هم خیلی برای ما جالب شاید بود که اساس و معلوماتی که اونا تشریح کردن خاصتا به صفت یک دکتر، نه به خاطر وزیر صحت عامه، هر مملکت قانون خود داره، هر مملکت دلایل خود داره که به کدام دلایل کدام قانونی را اونا روی کار میگیرن. لذا ما هدف ما فقط جواب به سوال است. خیلی جالب میشه که ما هم چیزی که اویدنس شواهدی که است با شما شریک بسازیم و بالعکس همچنان برای ما هم جالب خواهد بود که ببینیم. درست است؟
تشکر.
خواهش میکنم. دکتر صاحب نور کنم چیزی دیگه میخواستین بگوین به این ارتباط یا مویدنس برشان باز شیر کنیم؟
نه امو اویدنس ما با کتان شریک میکنیم، فقط اویدنس لابراتوار است. بعد از هیچ اویدنس وجود نداره و خود ما چک کردم که سایت های وزارت جرمنی هیچ خودشان هیچ استفاده نمیکنن.
تشکر. دکتر صاحب مسیولا جان به خاطر ما بیارین که به دکتر صاحب اجمل زید باز روان کنیم دمی نزدیکای شواهدی که پس بله بفرمایید.
حتما دکتر صاحب حتما.
دیگه فکر کنم تمام سوالات جواب داده شد. اگر سوالی نباشه درست است. اگر سوالی نباشه که ما پروگرام همیجا خاتمه بدیم. نظر شما دکتر صاحبایی که صحبت میکنن چی از دکتر صاحب عرفان نور، دکتر صاحب فیض و دکتر صاحب غریق؟ فکر کنم که تمام سوالا را جواب دادیم فعلا. خب تشکر از همه که در نشست امروزی ما شما اشتراک کردین. از پیشتان معذرت به این میخواهیم که نظر به سرعت اینترنت چی در ایجا بوده یا چی در افغانستان نتونستیم که وقتا فوقتا تمام سلایت ها را در ساعتی که دکتر صاحب وقتی که دکتر صاحب غریق پریزنتیشن میدادن با شما شریک بسازیم، ولی تمام پریزنتیشن ها را از طریق ایمیل برای شما روان کردیم. امید که بتانیم به هفته بعدی بهتر تمام آمادگی خود گرفته تا شما وقت شما بعدر نره و وقتی کمی که از به بالاترین درجه از استفاده کنیم. دکترای افغان از آلند در خدمت شما است. از دسترس ما چیزی که باشه همیشه در خدمت شما هستیم و ما از شما میآموزیم و با هم میتونیم که جامعه بهتر و مفیدتر و صحتمندتر داشته باشیم. تشکر از همه شما دوستا.
تشکر میکنم هم دکتر صاحب. پرویز یک گفتنی که برای دکتر صاحبایی که در افغانستان هست دارم که من بعد اگر سژنای بعدی هفته بعدی برگزار میشه ایمیل خود چک بکنن، خصوصا یکی دو روز بعد سژن که میمونه ایمیل خود چک بکنن. حتما ما امروزشان پروگرام ها را از طریق ایمیل شیر میکنیم، چون از طریق مسنجر فیسبوک واقعا لود زیاد میشه و بعضی مسیج ها و اسپم میره، ما از پیش ما گم میشه. از خاطر با ایمیل خود ساین این باشن، انشالله اپدیتی که بود با همراهشان شیر میکنیم.
و دوستایی که از طریق شما میتونن شنیده و شاید که از دوستا و همکارای شما باشن، چرا من 96 نفر دعوت کرده بودم به نظر به دلایلی که بود نتونستن همهشون حاضر شون، ایمیل کردن. معذرت ما را میتونین بر از اونا واسطه شوین، ما طبعا ایمیل هم برشان میکنیم. باز به هر صورت به پروگرام های بعدی کوشش میکنیم که کمبودی که امروز بود رو ما جبران بکنیم. سفیر جان کسی سوال داشتن گفتین؟ خب درست. روز خوش به همه، افطار خوب به همه شما دوستا و با امید ازی که صحت و سلامت باشین. خدا حافظ همه شما.
خدا حافظ.
تشکر. ممنون از همه.
ما و شما هستیم.
خدا حافظ شما.
تشکر.
تشکر. خدا حافظ.
تنها اعضای امکان ما می باشیم، متواقی دوستا همه میرن. دکتر صاحب مسیح جان هم همراه ما باشین، متواقی میتونن که برن بخیر. دکتر صاحب عرفان نور شما باشین، دکتر صاحب فایز شما باشین.
درست است دکتر صاحب.